Okay, we're going to get started with the afternoon segment. I'm very happy to have Sarah Romowski here, who is a school health economist with the Oregon Public Health Authority. She has graciously decided to join us for the training this year and share a lot of what she's learned in an agency setting about economic analysis. And I don't know much about this topic, and from what you all said on your applications, neither do you, so I'm really excited to learn alongside with you this new area. So Sarah's going to introduce herself a little bit too, to talk about her a little bit about her experience, and then go into the session today. So thanks again.
Hi everybody. I'm really excited to be here today and tomorrow and talk to you guys about economic analysis and return on investment. So I'm Sarah, and yeah, I work in the adolescent and school health section at the Oregon Public Health Division. I'm the school health economist / epidemiologist, so I just do a lot of data stuff like all of you. I got to do this training 4 years ago, and I remember around this time, Thursday afternoon, my brain just bleeding out my ears, so I don't know if that's how you guys are feeling too, but hopefully this will be a change of pace, something a little bit different. But I just wanted to say a word about how I even came into this work. So I, a couple of years ago, took a break from doing public health and went to work for Blue Cross Blue Shield. The dark side. It really is the dark side. And they hired me to do program evaluations, so they said, but actually they hired me to do economic analysis to figure out how much it would cost them to extend certain kinds of benefits to certain groups of people. And so I ended up getting paired up with a health economist, and we did a lot of return on investment analyses in the health insurance world, which I did not like, but it was very valuable, and I took it back to Oregon, and now I've been doing economic analyses in the public health world. So today and tomorrow, well, mostly in this first lecture it's a lecture, so it's pretty content heavy, and as we go on, I will talk less and you will talk more. So the first part is going to be mostly lecture. This afternoon, we're going to go through a case example together. And then tomorrow morning, you guys are going to be in small groups, and you are going to have the opportunity to work through an economic analysis in your group. Please stop me at any time if you have questions at all. I've tried to actually leave us time for that to work it into the presentation, so don't feel like you have to wait. So for this afternoon, I'm going to go over, I know you did some reading about this, but I want to just cover what the different types of economic analysis are, and then we're going to go through the components. We're going to go through how we set up the analysis. We're going to talk about using external data, which is a really important piece of doing this work, how we talk about dollars and treat dollars, and then we're going to talk about our costs and our benefits and doing sensitivity analysis, and then what happens when we put it all together. So I like this Dilbert cartoon because I feel like it sort of speaks to the fundamental tension around doing return on investment analysis and economic analysis in our work, is that it's not actually a part of our daily work usually. And so people want this information and they want it yesterday. And we all have busy lives and busy jobs, and it is hard to sometimes carve out the time to make the investment to do the economic analysis, but it's worth it. So when we think about return on investment, economic analyses, and public health, I think a lot of the work that we all do has a real upstream focus when we talk about it. Like, we're doing this program because we expect 10, 20, 30 years down the road it's going to impact whatever. It's going to reduce childhood obesity, it's going to improve women's health, it's going to reduce, rates of chronic illness. We kind of talk in that way a lot, and to people who are in our field and who are our allies, that makes a lot of sense. To people that we may be trying to convince or that we need to justify our programs, I think what it lacks is the economic piece. And so this is kind of where this comes in, is bringing this upstream focus that we have in public health into language that talks to a lot of people, which is money. It's really easy to go into this kind of work with a request like, I need you to justify why we need to keep whatever program it is that you're doing. And that's just the real world that we live in. That's not a bad thing, but I think one of the things I want to hopefully impress upon everybody is the importance of, before you start your work, you really want to frame the work that you're doing. Return on investment analysis is just one part of your overall analysis. If you hang your entire hat on that, you may back yourself into a corner. So there may be situations where you actually don't get a very favorable finding, and that doesn't mean that your program is not economically valuable. It could be because there's just not enough data out there for you to make the estimates that you need to make. Or it could be that, you know, your return on investment is really low, but you can justify the cost in other words. Or it could be that your return on investment is not that great, and you actually decide, like, maybe we don't need to have this program anymore. But it's just really important to be intentional about why you're doing what you're doing, to bring in as many partners and people who are interested in this work up front to talk about it and to help you think through what you're going to be doing. And try and resist as much as you can the pressure to make everything look really good, which I think is a pressure that applies in a lot of the work that we do. I've been to trainings before where people have presented on this topic and they've said, here's what cost-benefit analysis is. You should never, ever do it unless you're formally trained, because there's too many things that can go wrong, and you can make all kinds of assumptions that don't make sense. So hire a consultant to do this for you, which is not very realistic. And I think it's the same situation that we can all plug some variables into SPSS or SAS and create this beautiful model with all of these numbers that don't necessarily have context and content behind them. And it's the same thing with this. It's kind of easy to screw it up or to build a bad model, but it's still worth the exercise of doing it. And I definitely recommend that if you are going to start doing this work, it would be great if you find someone in your community who maybe has an expertise in this, who is just willing to review stuff for you, or get together with a couple folks who are working on it to bounce ideas off each other, just to make sure, because it can be really complicated. It's really good to have more than one brain checking all the assumptions that you're making, especially if that brain has some kind of experience in doing this. So I'm just going to walk through the different types of economic analysis. The first one is the cost analysis, which I very rarely see in public health. It's whenever we do this work, we're going to be looking at costs, but in the cost analysis, you're really doing an extremely detailed accounting of the cost, and you're really not looking at the benefits at all. So like I said, I feel like this is more sort of in the municipal world. There's cost utility analysis, which is more in the actuarial kind of insurance world, where the question that you're answering is, what's the cost to gain this additional quality adjusted life year, which is basically it's not just will you live longer, but will you live longer, with a better quality of life, or maybe you're going to live the same amount of time, but your quality of life will be improved. So it's a very complex kind of analysis. Is very specific, and I do see a little bit of it in public health. You guys should have a resources sheet in your binder, and there's a paper on the methodology of this. We're not really going to be talking about it, but if you're interested in it. And then the two that I see much more of are cost effectiveness analysis and cost benefit analysis, and I want to spend a couple of minutes talking about the difference between the two of these and why you might use one over the other. So cost effectiveness analysis answers the question, which intervention produces the best outcome at the lowest cost? It is inherently comparative. You cannot do a cost effectiveness analysis on a single program. You need something to compare it to. A cost benefit analysis is not necessarily comparative. You can do it on a single program. The question that it answers is, what is the benefit per dollar spent to produce the outcome that you want to produce? The cost effectiveness analysis traditionally looks at the short to medium term outcome. You want to immunize kids, you want to increase breastfeeding rates, you want to provide this service. Cost-benefit analysis is much more exhaustive. It looks over time, it looks at other secondary benefits and outcomes that might occur if you implement this program. You might look at things like what will happen to employment, what will happen to household income, what will happen to Medicaid enrollment, that kind of thing. So we're going to walk through a little very, very fictional example here of the difference between these two. So let's say that you are tasked with increasing the HPV immunization rate among females on Medicaid, adolescents. And you have these two program options, and your boss says, we want to figure out which one of these we should implement. I want you to do an economic analysis and give me your recommendation. So program A targets parents. It's very labor intensive. There's a lot of other parents going door to door, talking to them about the importance of why you should get your kids immunized. They have these like community nights where there's food and there's gift card incentives for them showing up, and it's media and like very, very intensive. It costs about $500,000 and it's very successful. They get about 80% of the kids in these families get immunized. Program B has a very different focus. It's very youth focused. It's like a social media campaign. They really engage youth to not only spread the word among themselves, but it's sort of couched in the context of it's good to do this because it shows that you're ready for more independence in your life. And this is part of growing into being an adult, making good decisions. What else do you think you could do with yourself if you know you can be trusted to make this decision? There's a whole branding component to it. And so it's a lot less expensive, $350,000, and it's not as successful, but they get about half their kids immunized. So, okay, do an economic analysis. So you do two because you're just so on your game. You're going to do two economic analyses. So the first one you do is your cost effectiveness analysis. And this is pretty straightforward. You have Program A and Program B. You have your total costs. They both targeted the same number of youth. And so if you're just looking at the money that you spend per youth, on the first one you spend $125 per youth, and the second one you spend $87.50. But then if you look at your success rates, which are quite different, in your first program you get 3,200 immunizations, in your second one you only get 2,000. So your cost per outcome immunization is less in Program A. So you might say, even though the total cost is more, it's more cost effective to go with this like very intensive parent effort. Well, then you also do a cost benefit analysis, where now you're not just looking at the immunization as your primary outcome. You're also, I mean, there's a reason why we immunize kids. It's not just to immunize them, it's so they don't get cervical cancer later in life. And not only are you looking at cervical cancer, but because your second program really appealed to this issue of making good decisions for themselves and being responsible adults, you also find there's a link between teen pregnancy and STIs. So the youth in your Program B, and again, this is totally fictional, where we can all draw really straight lines between our programs and direct outcomes. But you find that they have lower STI rates, lower incidence of teen pregnancy. And so in your cost-benefit analysis, you're projecting this over time. So let's say you're projecting over 10 or 15 years, and you actually find that your benefit in your second program is much higher per kid because you're able to count these other outcomes that Program A really isn't paying any attention to. And so that last figure, and we'll talk about NPV. NPV stands for net present value, and that is your measure in your cost-benefit analysis. And so you find that for every dollar that you're going to put into this program, in Program A, you're going to get $10 back, which is still really, really good. But in Program B, you're going to get $18 back. And so you might say, well, you know, this program looks to be more economically effective because of this analysis. So I just want to stop for a second and think of, these are two very different types of analyses, and you might use them in very different ways or for very different reasons. And I want you guys to just think for a second about why you might choose to do a cost-effectiveness analysis on a program, why you might choose to do a cost-benefit analysis for a program, or what are some of the questions that would come to mind if you were kind of deciding which route to go? Yeah.
So I think it depends on how long you're able to track those. It depends on the length of time of your study. So it sounded like in the cost-benefit analysis, you were able to track like what actually happened to those kids, whether they became teen parents, whether they, had these other sorts of outcomes. Whereas if you had maybe a shorter study or a shorter program or weren't collecting that data, you might only be able to get at that cost-effectiveness question.
Yes, so I think that what I hear you getting at is this issue of feasibility. How feasible is it to do the analysis that we're proposing to do? The other thing that you bring up is that a lot of the work that we do in this, we're not actually necessarily tracking the long-term outcomes of this particular program. And when we talk about external data, we'll get into that more. But a lot of this work is based on the best estimates that we can come up with. If we know, because this teen youth-driven program is evidence-based and someone else has already drawn a link between implementing this program and lower STI rates later, we don't have to follow these exact kids. We can use that, but I think that's a really good point. Anyone else? Reasons why you might choose one over the other? In the back? Oh, and all the way in the back? Oh, yeah.
I'm just thinking of context. So, I don't know. So Program A to me sounds like an immunization program through a funding agency that supports immunizations, and B might be more focused on broader issues among youth and a target population that's, I don't know. So some of it's just context and population and intent of program and what you're funding.
I think that's totally right on. It's a lot about who is interested in this and why are they interested in it. Maybe, and not that they don't care about long-term benefits, but maybe really what they need reporting on is immunizations, and that's it. And so these other things are great, but really they want to get at what is the most cost-effective solution versus if we were able to incorporate all these other benefits. Anyone else? I saw a couple other hands. Anyone else have? No? Yeah?
Well, I feel like you can almost do both, as what we've been talking about with our evaluation is more of a short term and a long term. Mm-hmm. So maybe start with the first one because initially you want to reach more kids and more youth to get more immunizations right away at a cheaper cost. But then as you start immunizing more, start transitioning, so you're going to have more of an economical benefit in the future after you get kind of the initial startup of the program.
Yeah, I think that's a really good suggestion.
Maybe you want to consider a break-even point as to which one to choose, because sometimes one has a bigger. You might want to look at break-even points because at a certain fixed cost, you'll be incurring a big fixed cost, but your variable cost will be lesser, and the other one might be the reverse. So it depends.
Yeah, absolutely. You might sort of have a threshold that you're willing to go over or not go over, and that might play into it too. Okay, great. So having said that, we're not going to talk about cost-effectiveness analysis anymore. I think what most people mean when they talk about return on investment analysis in our work is the cost-benefit analysis. They really want to know what are the long-term economic implications of spending money on whatever it is we want to spend money on. So I'm going to just walk through what I see as kind of the overarching steps to doing this work, and some of this will apply or not apply depending on your situation. If we were starting from this very pure raw space, we would say, okay, what is the problem that you want to solve, and then let's generate some possible solutions to try and solve that problem. But mostly that's not the world we live in. The world we live in is we have these programs going and we may need to do some economic analyses on them. But so we want to identify what our problem or our program is. We want to know what's our primary study question, what are our outcome measures, and this is where our logic models can really come in handy. who is our audience? And part of who is your audience is what are they going to use it for, do you think? Because it could make a big difference whether this is something that you think is going to go to legislators who are going to fight for your program versus just something that is internal, maybe to your office. And that matters not only for the choices that you make as far as choosing your costs and benefits, but it also matters as far as the investment of time that you are going to put into doing this work. Number 5 is maybe the most important piece, which is you need to define your perspective. And this is an iterative process. So you may define your perspective up front, and then you may change it and change it and change it depending on kind of what's happening. But the question you want to be asking is costs to whom, benefits to whom they should match. So if the costs for your program are paid for by your state general fund, and that's your perspective as your state general fund, your benefits should not include things like household income, because that does not, I mean, tax revenue would come into your state general fund, but personal income, I'm making more money, does not accrue to the same entity. What I tend to see a lot of is people just say, my perspective is society. So all costs that are incurred accrue to some kind of governmental entity or people or anything, and all benefits count. So individual benefits, government benefits, state, federal, city, county, whatever. And that choice has a lot of benefits because it gives you ultimate flexibility. However, I also think it opens you up to some criticism around not being specific enough. And some people don't care necessarily, again, depending on who your audience is. They may only really care about your state or county coffers. They don't really care, at least they may personally care, but as far as making your argument for your program or presenting your data. So you just want to make sure those match. You're going to decide on your time horizons. Like I said, cost-benefit analysis tends to go out over time, but that may be 5 years, it may be 10 years, it may be a lifetime. And this weird little thing that I have discovered is that, generally speaking, when you talk about lifetime in this work, it stops at 65. And the reason for that, it doesn't have to be that way, but the reason for that is that so many cost structures change drastically when you hit 65. There's Medicare, there's people retiring, their income really reduces, the taxes they bring in really reduce, their employment situation changes. So just something to keep in mind. Whether you're going to be doing prospective or retrospective, or really what I think tend to do is kind of a mix of the two. So you may have been running a program for a while, and you're going to use the data from that program to help you get some baseline measures to project out what would happen if I ran this for the next 5 years. You're going to choose your inflation rate and your discount rate, and we will talk about what those mean. I think inflation is a pretty common term to most people, but we'll also talk about discount rates. And then you'll do all your math, and you'll build your model, and you'll have your shiny results, and then you'll do a sensitivity analysis. And the purpose of the sensitivity analysis is what happens if you take one leg out of your three-legged stool? Does it completely change your model? Is your result really so driven by one of the benefits that you looked at or one of the assumptions you made? And sometimes that's the case and there's nothing you can do about it, but you just want to be really clear that if you change your numbers a little bit, do your results change a lot? And if so, you need to address why that might be the case. And then obviously you're going to document everything, all your limitations, all the assumptions you've made, and what this means for your program or for your state or for whoever. Any questions so far? Okay. Okay. So now we're going to talk about external data, which, as I said, is extremely, extremely, extremely important to this work. You really can't do it without depending on other folks. So just some kind of general principles if we're talking about external data is that you are probably going to be doing a lot of proxying. You're going to be making a lot of guesses and estimates based on other data sources that you find. And the first 2/3 of this process usually is really messy, and you may look up 20 or 30 data sources and you'll think, I'm totally going to remember where I found that, and then you don't. So write everything down. So there's two types, I think of them as of external data. And there's your topical data, and then there's your economic data. And your topical data kind of assumes, kind of to the HPV example we had earlier, it assumes you're not following this group of program participants over 20 or 30 years, which you're probably not. But you're hoping that someone else has done something really similar that you can use to help inform your long-term benefits. So we may talk about benefits of our programs, but we may not have very specific estimates of what they may do. So, for example, you're running a teen pregnancy prevention program because obviously you want to reduce unwanted pregnancies, but can you say, I expect it to reduce unwanted pregnancies by 10%, 15%, whatever it is. You want to get as specific about your projected outcomes as possible. You want to know, what will the non-economic impact of my program be? And the degree to which you can estimate this just really, really depends. But you might find that in the literature. You might be looking at census data, National Health Interview Survey data. It just really depends. So once you have kind of your topical data, or you feel like you've got enough to inform your non-economic outcomes, then you need to monetize them. And that's where you're going to be looking for your economic data. You want to know, how do I take these outcomes and put a dollar value on them that I can use to build my model? And I'm going to spend a couple minutes taking you through some good places to find this kind of data, and then take you also through an example. Okay, so like I said, I think in your binder there is a list of resources, and we are going to go through those for a minute here. Okay. So, is anyone here from the state of Washington? No. The state of Washington did an incredibly smart thing. Their legislature did a really smart thing, and they mandated the creation of this group called the Washington State Institute of Public Policy, and their sole purpose is to evaluate the public programs in the state of Washington that the legislature pays for, and basically do cost-benefit analyses and economic analyses on them. They're an incredibly smart group of people, and they have excellent, and if you were from the state of Washington, this would make your life a ton easier, but even us non-Washingtonians can benefit from the work that they've done. So I'm just going to show you here real quick. So if you go to their website, they have this benefit cost results. They changed all their framing to benefit costs so that we can focus on the positive, not the negative. And if you go into their results, you will see that they have done a ton of stuff. So if we go into like children's mental health, so these are like hardcore economists, and there's a lot of math in here that I don't fully understand, but they have these handy summaries where they've evaluated, for example, the economic impacts of doing different types of cognitive behavioral therapy on children with anxiety. And they tell you the total benefits, the benefits for the taxpayer, the costs. They give you a benefit to cost ratio, and this I love, they give you the odds of a positive net present value. So the odds that if you were to invest in this, you would get more than $1 back for every dollar that you spent. They don't have this for everything, but they have it for a lot of things. In public health, they haven't done their benefit cost analysis yet, but I know it's happening soon. So they're looking at some teen pregnancy prevention programs, school-based service learning. I definitely recommend. And if you are become a super hardcore geek about this. They have a technical manual. Well, I won't load it, but it's all the math and all the everything, and it's really fascinating, or a good way to get you to go to sleep at night. So depending on where you're at. So that's one resource I totally recommend. Another one that I recommend is the National Bureau of Economic Research. So every Monday, the National Bureau of Economic Research puts out 15 to 30 new papers on a variety of economic topics. I mean, a lot of them don't apply to the work that we do, but some of them do. And I put a couple of examples in your resources, but you can sign up for their RSS feed, and every Monday you'll get their little titles. These are all free if you have a .gov email address or some .edus, I think. Otherwise, you have to pay for them. But so I wanted to just look at one of these really quick, which was one that came out really recently on breastfeeding and child disability. So this is an economic analysis they did of the impacts of breastfeeding on child disability. And ironically, because it's an economic paper, but I think what it actually really gives is some really good topical data. If you can see in the abstract, it basically says that at the margins, breastfeeding children for a longer time is associated by a 0.2% reduction in disability status, which is really specific and really useful if you were looking at the relationship between breastfeeding and disabilities in kids. So they have a lot of great stuff, and I definitely recommend checking it out. Let's see, the other one, I'm just show you. If you already do teen pregnancy stuff, I'm sure you're familiar with the national campaign. They put out cost estimates, not every year, every couple years maybe. They do state level estimates on the cost of teen pregnancy, of reducing the teen pregnancy rate, reducing the teen birth rate. If you are doing anything with Medicaid costs and you can't really get good access to your Medicaid cost or utilization data in your state, I'm sure a lot of folks are familiar with this resource already, but Kaiser runs state health facts. You can get Medicaid spending, you can get utilization. They also have the matching rates, so what's your state match for the state portion and the federal portion of Medicaid. There's inflation calculators on here, which will be useful to you. And then there is this cost effectiveness analysis registry, which is run by Tufts. And this is a nice place to go. They only give you abstracts, but it's a lot easier than searching like your general Medline or whatever if you're looking for other economic analyses. So if you go to the registry and you go into search, and I wanted to search like infants, there's a lot of different articles here, and they'll just give you the abstracts and kind of the high level findings, and then if you wanted to go actually pull the article, you could go through your library or whatever. But it's a nice resource to just like zero you in quickly on what's out there from an economic perspective. When you are looking at external data, it's going to be pretty much impossible. Well, I don't want to say impossible. It would be really great if you could find someone who had done a study with your exact population and your exact geography and your exact time frame. Because, well, I guess then you wouldn't really have to do it yourself because someone else had already done it. But get as close as you can to the population and the details of your program that you're looking for, and to the extent that you may need to make adjustments that we'll talk about. Or if you can't, then you just document it and you say, I use national data because I couldn't find state level data or whatever. You want to make sure that you're converting any dollar values you're getting from external data, you're converting them to something common that you can apply to you. So dollars per kid, if they're just giving you a total like savings figure and you don't exactly know what's included in that, it's really hard to take those general ballpark estimates and apply them and put them into any model that you're building, because you can't break them down into the individual pieces that go into that. So to the extent that you can convert something to a common unit, and that can actually be something that gets really tricky if you are dealing with a large figure that you get, like National Campaign to Prevent Unplanned Pregnancy. They do give these really large numbers, and you could say, well, I'm going to divide it by like the number of people in my state or the number whatever, and that's where your analyses can kind of go off the rails, because you just want to make sure that if you're looking at other sources, you know as much as you can exactly what they did to get there. We had a situation in our state where we were using these excellent looking fact sheets from a national organization, and they were estimating the economic savings of linking public health with this education program, and they had a fact sheet for Oregon, and we were like, this is great. And then we tried to replicate it ourselves, and we couldn't replicate it ourselves, and we contacted the organization to try and figure out like what was their methodology, and they basically were like, the first answer was like, we didn't save those files, and then like, we just got it from this professor at Columbia, but he doesn't work there anymore. And in the end, it was like, we can't help you. And so it was like they were so perfect for what we were doing, and we had to throw them out because we just felt like we couldn't stand by it. And I just want to take you through one little article here. So apparently I'm on an immunization theme. Where did my thing go? Where's my mouse? Wait. Oh, there we go. Okay. So let's say we're looking at the impact of immunizations, which this is pretty well established already, and you found this this is an excellent article. It just came out in Pediatrics like a month ago. Economic Evaluation of the Routine Childhood Immunization Program in the U.S., 2009. And you were like, great, I want to take this and like apply it to my locale. And so you read this article, and you get down to this really awesome table, which is somewhere. No, here we go. Okay, so here they have this great summary for for these vaccine preventable diseases. They've estimated, if you get it, what's the probability you're going to get hospitalized, what's the average number, the length of stay that you're going to be in the hospital, what's the cost per hospitalization, and then what's the cost per outpatient visit. And this is national. So if you were taking this and you wanted to put it into your state, you could just take it and you could say, these are national estimates. I'm going to assume they pretty much apply to what we're doing here. Or you could try and be a little bit more specific about converting the data. And you could think about, like, are our immunization rates in my locale comparable to national immunization rates? Or what do I know about medical costs in my state? Do I think that the costs of hospitalization in general tend to be higher than the national average? And that may be something you have access to, and it may be something you don't have access to. But that kind of stuff tends to sort of be floating out there in the literature. And then, well, hospitalization days I wouldn't think would really vary by locale, but maybe. But as much as you can take this, and like, I know in Oregon, our hospitalization costs tend to be higher than average. So I might say I'm going to multiply this by like a 10% increase value, and that's going to, if I'm building a model, that's really going to change my benefits, because if I'm talking about how much money I'm expecting us to save because now we're not sending kids to the hospital because they have diphtheria, my costs avoided are going to be higher. The other thing that we want to pay attention to here is all costs are in 2009 dollars. So whenever we're doing these analyses, we want to make sure that all of our dollars are in the same year. So that's going to often mean converting dollars to different years so that we can make sure we're talking about, we're comparing apples to apples. And we'll talk about that a little bit too. Oh, actually, I'm going to show you. Oh, wait a minute. Oh, yes. Okay. we're going to talk about it right now. Okay, so we're going to run through what the terms are that we need to know about when we're doing this. And the first one is inflation, which is kind of sort of what we're talking about. So there's two different ways that we need to pay attention to the inflation rate. I mean, I think we're all sort of familiar, inflation accounting for the rising cost of goods and services. The first way that we might want to pay attention to the concept of inflation is the one we were just talking about. So you have dollars estimated in some other year, and you need to convert them either forwards or backwards to whatever year. So this last piece is actually not on your slide. I added it, but because I just found it and I was so happy. But so this is a professor, poli-sci professor at Oregon State, and why do I keep losing myself here? He runs this really text-heavy website, but yeah, it's kind of crazy. But this, if you go here, this very, very first link, conversion factor. He always has the most recent, like, complete year at the top. So conversion factors. So let's say you wanted to convert dollars from 2009 to the future. He's developed his own estimates to do that. Oh, here we go. So he actually gives you these like conversion factors, and he gives you instructions for how to convert your dollars forwards and backwards. So $100 today is worth what in the year 1774? A lot. And so this is kind of I find this really useful because you know exactly what math to do, and you know exactly what rate you're doing to put all your dollars in the same year. The simpler way, I guess, to do it, depending on what you're trying to do, is in your resources, I included a inflation calculator that the Bureau of Labor Statistics puts out. And so they don't have quite the same range. They do not go back to 1774. But if I wanted to know how much $500 in 1980 compared to today, wow, is worth almost $1,500 today. So this is an easy way of figuring out your dollars. So that's the use of inflation for putting everything in the common year. The other use of the concept of inflation is that as you are building your model, you are going to be building it over time. And so for every year that you're estimating your costs and benefits, you're going to need to apply an inflation rate so that you're being true to the value of your dollar. And we'll talk about that more. If you are doing an ROI that includes both like medical costs, claims costs, as well as just regular inflation, you may want to consider having two inflationary rates because historically medical inflation has been higher than regular inflation. Another resource in your list is there's a website called YCharts, which gives you kind of historical inflation figures, annual inflation figures for both medical inflation and just run-of-the-mill inflation. So if you're trying to figure out what should I use for my inflation rate, that might help you. Questions about that? Okay. So the second term is a little bit harder to get your head around, so I'm going to try and explain it in a couple of different ways, and hopefully one of them sticks for you. The discount rate. The discount rate is the concept of that the dollar in today's terms is not the same as a dollar in the future. So a dollar today is worth more, or excuse me, is worth less than a dollar in 10 years. And so another way to think about it is you have money to spend on this program. You could spend it on the program, or you could invest it in something that's going to give you an interest rate, or it's going to give you a rate of return. And so by choosing to invest it in this program, you are foregoing a possible money that you may get back. So you need to account for that. You're basically like, as you build out your model, and we will see this year by year by year, what's the value in 5 years, what's the value in 10 years, you're going to be applying this discount rate to your dollars. The other way to think about it is the discount rate represents the patience of the decision maker. So the lower your discount rate that you set to 1%, 2%, the more future-oriented you are, and your dollars will be discounted less, and your benefit will be higher. The less patient you are, the higher discount rate you're going to set because you really value today's dollars much more than you value the future dollars. This gets super, super complicated, and really I just recommend you look around and see what everybody else is doing, which tends to be around 2.5% or 3% is what I have seen the most. Some people say, well, especially if you're doing like a city or a county level analysis, you could say, well, if I'm doing a 10-year analysis, I could invest this money in a government bond at 10 years. So what's the interest rate on a 10-year government bond? It's like 2.5%. This bottom part is also not on your slide, and maybe I regret putting it up here because it looks really complicated and confusing. But there is a formula to calculating your discount rate. It only works if the amount of money you're talking about is the exact same every year. So you're running a program and you expect to get $100,000 back every single year for 10 years. You can use this little formula to help you calculate it out. But that's not always the case. You may have different numbers in different years. This bottom website, this wikihow.com, it looks kind of like a crappy website, but they have a really good explanation of discount rate. So I don't think that's on your slide either, sorry. Oh, it is? Oh, excellent, okay. Okay. And then the last concept is, or two concepts, I guess, we've sort of already talked about. So net present value, you've got your costs over time, you've got your benefits over time, you're gonna apply this inflation rate, which is gonna kind of work at odds with your discount rate. So your inflation rate's gonna make everything go up, 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 your discount rate is gonna make everything go down, down, down. You add it all up together and you get your net present value. And then you have your ROI ratio, which is what most people care about, which is you being able to say for every dollar that you put into this program, you're going to get $10 back. And so you just take your net present value, you divide it by your costs, and then you put the ratio to $1. And again, we'll do examples of these. Oh, right. So here's just a little tiny example of how this works. You have this very, very, very small program that costs you $100, and you're running it for 5 years, and you estimate every year you're gonna get a $100 benefit per year. So your first year, $100 benefit, there's no inflation, there's no discount rate, it's just what it is now, so $100. Your second year, you save $100, you inflate it 2%, yeah, it's really $102, but then you discount it, so it's really only $98.55. And so on, and so on, and so on. So if you hadn't applied these things, you would have said, oh, over 5 years, I'm going to have a $500 benefit. But really, when you do what you're supposed to do, it's really only $485.72. And so your return on investment for every dollar you put in, you're going to get $485 back. Does that make sense? Great. Okay. So now we're going to talk about costs. I like to think of this concept of cost as like an axis. So you have these two concepts, like these are not four distinct buckets. You kind of have your direct costs and your indirect costs on one axis, and then crossing it the other way, you have startup costs and future costs. So, I think we're pretty much all familiar with this concept of direct costs and indirect costs. But when you're thinking about the cost of your program, sometimes it'll be really easy because it'll just be like your budget's $5 million and it doesn't really matter what goes into that $5 million. But sometimes you really need to be very specific about staff salaries, fringe rates, equipment. Direct costs would be like claim costs or any other medical costs or just your program funding stream. And then any overhead you need to account for. On kind of the other axis, you may have costs that you would incur in the first year that you wouldn't incur, later. So you may have like initial ramp up of your program. You may have training needs or hiring needs, or maybe you only have them every 5 years or something. I actually have never done an analysis where I've taken future costs into account, but in theory, if you were really being super on the ball and you were accounting for like people's raises and pension, I don't even know how you would actually do that, but in theory, insurance costs. When you're thinking about your costs, again, you want to think about what are they for? Are they really the cost of your actual program? Are they one-time costs or ongoing costs? What's your perspective? So who is actually paying it? Is it a federal cost, a state cost? Obviously what the amount is, and then what the source is. Is this something that you know for sure, or are you kind of just estimating based on like your best guess? So we're going to go back to our HPV parent education example here. And we are brainstorming. I mean, I already told you the costs were $500,000, but we're brainstorming what our costs are. So we're like, okay, we've got the staff person, we've got materials, we've got media and incentives, and then the actual cost of the immunizations themselves. And we've got, estimated amounts for these things. But in the payer column, some of these are Title V funds, some of them media advertising. This would never fly in my state, but maybe somewhere you could spend $100,000 on media out of your general fund. And then the HPV immunizations themselves, since we're focusing on the Medicaid population, those are going to be Medicaid costs. The time horizon is different. For most of them are annual, but like you may be able to reuse those signs, so that's not totally an annual cost. And then where you're going to get the information from, and most of these are pretty straightforward. When you're thinking about your costs and your benefits, you want to write down everything that you can possibly think of and as much information as you can, and you may throw them out later because they don't make sense to include in your analysis, but you at least want to, not only for yourself, but to someone else, if they're like, why didn't you include this? And you're like, I thought of it, but then I didn't do it because the perspective didn't match, or I couldn't get the data, or whatever. So, very similar thing for the benefits. With benefits, oh yeah, sure.
On the other side, say you're looking at the benefit of your program, and one of the things that you do in that program is to make linkages with other agencies. So you do like a warm handoff or referral to like an employment thing. Do you account for the costs of like that staff percentage in the employment thing?
Yeah, so yes or no. You can kind of make yourself crazy with like trying to parse out every well, it's a staff person, but really only 90% of their time is spent on doing this thing. I guess it just really depends. What the example that you gave, it sounds like they're a staff person, unless they're doing that all the time, I would probably just count their salary, for your program. Does that make sense?
Yeah, so say like it's our program and then they link it to like another community program that's totally separate as like a referral. Do I count the person in that program?
Oh.
Like in that other entity, it's like not necessarily our program.
Right, so that depends on a couple of things. First, it depends on what your outcome is. Does the fact that they're going to that other agency, is that like crucial? Do you have an example in mind?
Yes.
Okay.
So, for example, we're starting a study and we're starting it in August, and we'd like to do economic analysis on it, and it's essentially giving dads home visitors whose partners are already in home visiting. So it's above the additional home visiting stuff that mom gets, giving this dad the same kind of supports. Does his mom baby's outcomes improve? And how much does that cost? So as part of it,
Interesting.
he could, just like any home visitor, the needs are unique to different individuals. So like a dad might, with his own case manager, might need a connection to like someone in an employment program to help him with like a CV. So do I count that?
I hear you. I would say no, because that might be something that you would talk about in your like summary or limitations or whatever, but that service would never have been provided had the home visiting not occurred. And so that's not a cost of your program. Yeah, that's what I would say. Sure. So when you're thinking about your benefits, you really, want to be thinking about what kind of time horizon are you talking about here. If you're talking about over the lifetime, or you're talking about 5 or 10 years, the longer out you go, probably the more benefits you're going to be able to / be forced to include. And again, you want to be thinking about who is going to be realizing the benefit of this. Is it accruing to the same or entity or whatever that your costs are being borne by? And then how feasible is it? And I think this is where we run into some challenges, because there's a lot of benefits that we'd like to be able to estimate, and they may be possible, but it would take so much time to be able to do it, we just have to toss them out. So in our HPV, parent education example, we brainstormed all of the benefits, or some of the benefits that we might expect to see over the lifetime. And so obviously the primary one is going to be lower incidence of cervical cancer. We also decided, we thought about income and tax revenue, because if people aren't getting cancer and or they are not dying of cancer, they are going to be earning income and they're going to be paying taxes, and that's going to be going to the states and the feds. And then lower incidence of genital warts, wanted to include that in there as well. So these were our benefits. We came up with an economic definition, a very vague one, but at least to give yourself an idea of how you might start to monetize this. You want to write down the benefits. You want to write down the sources. Do you think this data is available? And then how feasible is it? So we went through this process, and the income and the tax revenue seemed pretty feasible. That data is pretty easy to come by. Cervical cancer, yes, we may not be able to get it to our exact population. Genital warts seemed really hard to really get at a good estimate. And our economic definition, and again, this is totally fictional, so it may be completely wrong, but was reduced prescription drug costs. And that does not seem like it would be a very substantial benefit that we would see. And so because it was hard to do, and we're like, no, we're not going to do it. Oh, that reminds me though. One other resource I wanted to show you. If you are doing anything with, you expect your program to increase, or to increase income, increase tax revenue, there's a great little resource in order to estimate tax revenue, and it is on your list, and it is also run by the National Bureau of Economic Research, and it's called the Taxum Calculator. And I'm going to show it to you really quickly. This benefit tends to apply almost regardless of whatever program you're estimating. The chances are, if you're improving someone's health, you're improving the chances that they're going to be able to work more to their fullest capacity. So if you were doing this for like 1 million individual people, you can upload it or run a data file, but I've never done that. You can calculate for a single taxpayer for any year between 1960 and 2012, what their state and federal tax burden would be. So this is really like, it's pretty basic, but it does actually give you a pretty decent idea. So you would just put in your year, you put in your state code, which I know for Oregon is 43. Are they married or single? And I pretty much keep everything just like 0, 0, 0, 0, 0. They have no dependents, unless you know for sure that they would. And I just enter like, okay, if they were to earn $25,000 in 2006, and they had nothing special, no like whatever. Again, no Social Security, no itemized deductions. And it gives you this nice, really ugly but informative printout of, it tells you what you put in. Oh, apparently that was Tennessee. Okay. So it tells you here, federal tax calculation. I don't know why it adds $1 to it, but so the regular tax, oh wait, I can use this. No, I can use this. Yes? Haha. Okay, So your tax that you would expect to pay to the federal government on $25,000 is about $2,100. And the tax that you would pay in Tennessee would be about not a little more than half that, so $1,250. So again, it's just a pretty simple way to look at how to estimate any impact on tax revenue. Really? No income tax? Did they have them in 2006?
No, it's income. Yeah, I'm pretty sure it's income.
Huh. So don't use it for Tennessee. Okay, well that's an error.
I think it said exemptions.
Oh, good. Thank you. Okay. So that was a poor example. Don't pick a state with no income tax. Thank you. But if you actually picked your state and you actually looked up to see what number it was rather than just guessing, then so that's how you might get at tax revenue. Okay, so now you've brainstormed all your costs, you've brainstormed all your benefits. I kind of gave this away already, but you want to put them together, and you again want to make sure, are they accruing to the same entity? And you may have had this idea in the beginning, you may have picked your perspective, but then when you look at all your costs and benefits together, it does not make sense for you to keep that perspective, so you want to change it. And how feasible is it? Can you do it within a timeline that is reasonable for whoever is requesting this for you? So here we have our costs that we talked about, we have our benefits we talked about, and we decided we're going to keep all of our costs, and we're going to, our perspective is the government, basically, state and federal government. So because of that, we're only going to keep our Medicaid costs for cervical cancer, because that accrues to the perspective that we're interested in. We're not going to keep income because that accrues to individuals, and we don't care about individuals for this purpose. We're going to keep the tax revenue, and we're throwing out the genital warts, even though the perspective is correct, but we've decided that it's just too hard to estimate with any certainty what the level would be, and it's probably not worth it anyways. So these are all the elements that we're going to put in our model. Any questions about that? Okay.
Sarah, can you talk a little bit more about the increased tax revenue? How would you just assume that someone is going to go from zero tax revenue to whatever tax revenue they would have if they had the average income for that state?
Sure. So for an example like this, and we'll kind of look at it a little more closely, but for an example like this, what I would think about first is if they get cervical cancer, well, first of all, they might die, in which case they're not going to be bringing in any tax revenue. So I would try and figure out what's the chances that that might happen, what's the average income for someone who, you try and get at your population, right? You're looking at maybe someone with a high school education in your state, what's their median income? I'm going to estimate the tax revenue on that, and then all of that is benefit, because if they die, there's no tax revenue. Or you might say, and this would get a little trickier, but you might say, well, if they get cervical cancer, they may live, but they may have significantly reduced earnings for, 3 years, 2 years, whatever. And that's where you want to go to the literature and say, like, has anyone done anything on this that I can use to try and estimate, okay, they're going to suffer a 50% reduction in income for a 5-year period or something like that. It's a lot of, it's like sleuthing, I feel like. It's like being Nancy Drew, which is kind of fun. Yeah, does that make sense, Rachel? Okay. Okay, so we are going to actually look at how we might calculate this. And I use Excel for all of this, and I know you guys don't really have laptops or anything, so when you're doing it later, you're going to have a really fun time doing some of it by hand. But I am happy to email you my Excel templates if you would like them. I would be happy to do that. So we're actually going to take a look at this, what this looks like. Yes, okay. So And again, this is really something that this is how I like to do it, but you could come up with your totally different way. But basically what we're doing is we are brainstorming any possible piece of information that we think we might need to calculate this. So we decided for our model, we're going to look at two benefits. We're going to look at cervical cancer, avoiding cervical cancer, and we're going to look at increased tax revenue. And those are both come from the same outcome they both are the same outcome as of you don't get cervical cancer, so you make more money, and you don't have the claims costs, and you don't die. So a lot of times when I do this, I over brainstorm. I come up with like all of these possible pieces of information, and I only use half of them, but at least I know I've thought of them and have tried to come up with what the answers might be. So I set up my little spreadsheet. I have my input, whatever the concept is. I try and estimate my amount. I'm going to make this smaller, actually. Can you guys still see that? Okay. I will say which benefit it is for. Is it for the Medicaid or the Medicaid benefit essentially, or is it for the tax benefit? And most of these are for both. Wherever I found this number, I will write down where I found it from. And then any assumptions or anything that I might want to know later about where I got it, how I did it, what the limitation is, anything like that. So for the very first one, I was like, well, I should probably know what the incidence of cervical cancer is among women if they don't get vaccinated. And so I probably Googled that and went to the Sera registry and found a national estimate, and so of 0.66% basically. And so I said, like, I couldn't find an Oregon-specific rate. I don't know if the rate of this varies by like socioeconomic status, because my population here is Medicaid, young women on Medicaid. So this isn't really my area, so I don't know. Are they more likely to develop cervical cancer? But anyways, I'm writing all this stuff down. Okay, so 0.66% of them over the lifetime have a chance of developing cervical cancer if they don't get vaccinated. I want to know what the median age for the cervical cancer diagnosis is, because essentially the path of got vaccinated and didn't get vaccinated is going to be exactly the same until for my purposes, until they hit this median age. Some would get diagnosed earlier, some would get diagnosed later. But for the purposes of this, we're just saying, okay, median age is 48. So really, no benefits that I'm talking about are going to start showing up until they hit 48 for the purposes of my model. You can make anything more complicated if this was your area and you knew it really well and you were like, well, I'm going to figure out like what percent gets cervical cancer at 42 and what percent wait till 50 or whatever. But again, we're just trying to keep it relatively simple here. So that I got from the CDC. I think it's the same thing, no state specific. I thought I should know what the survival rate of cervical cancer is. Are they likely to actually live, or will they just go through treatment and maybe have reduced income? And so 67%. That was the 5-year rate. That was the best I could do. What's the efficacy of the vaccine? 98% is what we're seeing now. And then what is actually the cost of treating where are we here? What's the cost of treating a case of cervical cancer for Medicaid, because Medicaid is our population? And so I found this article on the NIH website from 2010. Oh, right, this was actually done in North Carolina, but it was, again, the best I could find. So 30,917. 2000, I didn't actually put it, but I should have put whatever year dollars this was, because I'll probably need to translate them to some other year. I don't think I actually did that on here. Okay. Risk of mortality, so if you actually get cervical cancer, which is a little bit different. I think this was one of those things where I was like, I'm just going to put everything in here that I could possibly think of that I'm going to need. So I have a 5-year survival rate. I have a risk of mortality if you get cervical cancer. Expected years of life left after you get diagnosed, which was 6.2 years. And then I want to know, okay, let's say you get vaccinated and you don't get cervical cancer, what's your life expectancy? Because that's important. It's like the if intervention, without intervention. So 79. And then I'm doing this for Oregon, so I need to be able to figure out what percentage of these dollars are going to be Oregon dollars and what percentage are going to be federal dollars. So 37%, and then the feds portion is 63%. And then I went and looked what the median female income is in Oregon, $25,000. I got that from the census website. And then I went into that tax calculator and did expected state tax revenue per person per year, expected federal tax revenue based on this income level of $25,000. Oh, and then I had this idea I was going to like estimate over age 65. So I was like, well, they're probably making less money, but it just got really complicated. So again, I would probably delete these. But if she's under 65, she's going to be making, or over 65, she's probably going to be making a lot less money. And so I did the taxes for that income level as well. Oh, okay. And then I wanted to say all of my dollars are in terms of what year. I'm basing this all on 2010. I think that's because that's when the incidence rate was. Okay. I know that was a lot. Is there questions on that stuff? Okay. So I need to set my inflation rate and I need to set my discount rate. So I went to this inflation website to see what the historical inflation rate has been. I set it at 2.5%, which is actually maybe a touch high. And then I set the discount rate at 2%, which is actually low. I don't really know why I did that, but 2 to 3.5% is pretty average for your discount rate. So those are all of the assumptions that I felt like I needed to state in order to start calculating what my benefits are if they get immunized, they avoid cervical cancer, hopefully they avoid death, the Medicaid costs are less, the income is more, the tax revenue is more. Okay. So now I'm going to do my Medicaid calculation. So I just am looking at how much money is the state going to save, how much money are the feds going to save in Medicaid dollars by getting these young women immunized. So I already said we're targeting 4,000 of them. 80% was the success rate of our program, so we have 3,200 women that were vaccinated. So I said, if they hadn't been immunized, I just multiplied my number of women vaccinated by my expected lifetime incidence of cervical cancer. So without the intervention, how many cervical cancers are we expecting to see? We are expecting to see 26.32. And if they got the immunization, how many cancers are we expecting to see? Well, it's not a 100% efficacy rate, but we're expecting to see 5.68. So by implementing this program, we're projecting that we're going to avoid nearly 21 cases of cervical cancer. And then because I had projected out the survival rate and the average life years expectancy, I can say the number of expected deaths without the program, and then the number of expected deaths with the program. So let's see, for this one, I took the number of expected cancers, which was 26, and I multiplied it by basically the 5-year death rate for cervical cancer. And then I did the same thing. If they got the immunization, how many deaths are we expected to have? Deaths avoided, nearly 7. Now, again, major limitation is that this is based on 5-year survival rates, not lifetime survival rates. So that would probably change things. Okay, so I have all of my inputs that I feel like I need to do this work. And I like to see everything, so I like to just go year by year by year. It kind of is a little tedious, but I feel like it just makes it really, really clear what you're calculating, how you're applying your inflation rate, how you're applying your discount rate, and if anything looks weird, it'll pop right out at you immediately. So I started out with my year one, and I'm assuming, I guess I decided that these girls are they're 13 years old. So I start out 1 through 5. Now, if you remember, the median age of cervical cancer was 48. So nothing is happening until, well, I said 49, but nothing's happening. So I hid all of these rows because they all say exactly the same thing, basically, which is nothing's really happening. The only thing that's happening is inflation is happening, discount is happening. It's just that there's no money to actually be counted during that period. So fast forward to 37 years. This is way longer. Most cost-benefit analyses do not go out to however many years this is, a lot, but just for these purposes. So we get to year 37. The women are age 49, and every year that we're doing this, I'm increasing the inflation rate, and I'm increasing the discount rate. So we set our inflation rate and our discount rate factors up front, and I just have formulas plugged in, and again, I'm happy to send you these templates so that you don't have to do all of this over yourself. But basically, okay, the first year it's 1%. The second year, I'm taking the year before and I'm multiplying it times 1 plus whatever my inflation rate is, so 1.02. And then the next year, I'm doing the same thing. So you're always basing it off the previous year. So we get to age 49, and all these savings over here are 0, 0, 0, 0, 0 until we get to that point. And my Medicaid savings, now I have to remember what I did here. Oh, right. So I estimated these were the number of cancers that I avoided. And then this was the cost of treating the cancer. So that was how I estimated my savings. So this is just raw numbers. This is without any inflation. This is just a pure, simple number, 637,000. And I did this for 6 years because that was the I'm thinking this through, and I'm thinking I made some poor decisions in doing this, but this was the expected, the life expectancy of the cervical cancer. But these dollars are pure dollars. They're not inflated yet. They're not discounted. They're just the benefits. So I have that because I want to be able to see it. And then I have the sort of the treated dollars. I've applied my inflation rate by taking my raw numbers, multiplying it by my inflation, and dividing it by my discount rate. So my number's going up because of inflation, and it's going down because I'm discounting it. And because my inflation rate is higher than my discount rate, overall the numbers are going up. So these were the numbers I had for these 6 years of my Medicaid savings, and I only counted it for those 6 years, which again, I probably should have made a different choice. But so for Medicaid, I'm summing up my my net present value of my benefits, my treated benefits, my benefits once I've inflated and discounted, and I'm saying that it's basically $5.1 million. My cost of my program was $500,000. Therefore, my my return on investment ratio, or my cost-benefit analysis ratio, is for every dollar you put in, we're expecting just for the Medicaid cost portion to get $10.21 back. Oh wait, no, sorry, that's wrong. This is the Medicaid part. Okay. So the Medicaid part is, if I add this up, it's $4.6 million. So that's my estimated savings just for the Medicaid claims costs. Okay. So I then took some really, really rough estimates and decided that for those women that basically survived, they are now earning income. They would have died if they didn't get the program. I'm estimating what their tax revenue would be. So I'm like, okay, the number of women that we're expected to survive times the taxes that we would expect to get in is what I expect for basically my lifetime. $24,000 a year is what I'm going to see in tax revenue from these, 20 surviving women that I'm expecting to have. So this is my number that's untreated. I inflate it, it goes up. I discount it, it goes down. Because my inflation rate is higher than my discount rate, overall, my treated dollars are higher than my raw dollars. So I do that for every year. And so I'm summing up all of these over the lifetime, and then I'm getting to this. No, this is not a pointer. Over here. So over the lifetime, $4.6 million is what I'm expecting in Medicaid savings. $485,000 is what I'm expecting in tax revenue. So clearly, these were the only two benefits I was counting, my net present value is very, very, very heavily weighted towards Medicaid. 91% of my benefit is because of that Medicaid, which kind of gets to our sensitivity analysis of that means that whatever assumptions I made for that Medicaid portion are really important to keeping this. Now, $10 is a really good ratio. So even if they were off and it was like $6 or $8, that's still really good. But we kind of want to avoid having something this lopsided if possible. So if this is what I had actually done, I may actually go back and see about, are there some other benefits that I want to include, or do I really, really, really want to double check these Medicaid ones to make sure that I feel good about them. Okay.
Can I ask a question? Yeah?
Yeah.
Okay. So when you're calculating out the tax benefit, are you doing that for the same years as the Medicaid benefit, or only after that Medicaid?
I only did it for after.
Okay, why?
Because, why did I only do it for after?
Because wouldn't they be working if they weren't diagnosed that entire time period?
Yes, they would be.
Okay. I just wanted to make sure I was thinking about that right. And then also, there was another question I had, but I forgot it now.
The thing I didn't account for is the question Rachel had earlier was they may be surviving but have reduced income. So they may, it's not just they lived or they died, right? They could survive and have a reduced income, and that would also that would be another population of people that were not, or like another group to try and estimate their tax revenue, but that was complicated.
And are we also assuming that these women are going to be in Medicaid their whole life and assumptions like that? So you'd have to make all these statements at the beginning. Being
Absolutely.
Okay.
Yes. Very good point. Yeah. We're assuming that this population of teens that we're talking about here are on Medicaid ad infinitum, which is a really good point, actually, that if I had been thinking about it, I may have tried to find something around I don't know if this exists, but what's the chance that is the case? I think the other thing is generally we don't count all of our benefits, so because it's too hard to. So there's always the flip side of here's all the things I didn't account for in this, and so it kind of, to me, sort of it makes up for a little bit of I may have overestimated this benefit over here because maybe 80% of these women are on a Medicaid path and 20% of them are on private insurance. But I also didn't count for, all of these other things over here that would have increased my benefit. Does that make sense?
Can I ask a quick question too?
Yeah.
So I'm just wondering, was the $30,000 approximately for the treatment cost, was that for their entire course of cancer?
That was... It was what and again, if you were doing this for real, you would want more than one citation for your costs.
Well, what I'm just wondering is why you would have, so you did the 30,000 times what, the 20-something cancer cases you were gonna avoid? And why would you add that up for 6 years unless you were saving unless the cost of the treatment was $30,000 each year? Does that make sense? Because if they're surviving for 6 years, they're not necessarily, their treatment cost isn't an additional $30,000 each of those 6 years.
Very good point.
So I just,
Yep.
why did
very
you
good
do
point.
that?
You're right.
Well, I just
No, and so that is, you're right. I shouldn't have done that. And I think, again, this really speaks to having a bunch of people to like talk through this stuff and challenge your assumptions and think about like, well, what if I did this, or I shouldn't have. Double counting costs or double counting benefits, I think is really easy to do. So yeah. No, it's good. Yep. Yeah.
I have a question about when you find kind of these citations in the literature for cost-benefit analyses, and the one I'm most familiar with that I've seen lately, and I've seen people cite it, is for water fluoridation, like what it saves in treatment costs, and it saves something like $38 in treatment costs downstream. But I've seen people cite it a lot and have encouraged me to use it. So I went and looked up, and you have to kind of play this game where you look at multiple different sources and track it back to the original source, because no one ever cites the original source.
Right.
But the original source is back from in the 1980s. Does it make sense to continue using that citation, given that all the economic analysis was done back in the 1980s?
You know, I think that's a really valid question. I would have a lot of reservations about doing that, for sure.
Yeah.
And if I did do it, it would be because there was nothing else available.
Yeah.
And
I think I ended up not using it for that reason, but I
Yeah.
had people tell me, well, you know, you need to put it in there. And I'm like, no, I
think
don't.
it gets really tricky when some of these issues we're working on are very political in nature, like fluoridation can be, like immunizations can be, where there's a lot of pressure to count certain things or not count certain things. I think one thing I try to do is not really use anything if I can only find one number. If I can only find one place, and it doesn't have to be like the exact same figure, but if I can only find one, you know, cost estimate for cervical cancer, you know, or I find two and they're wildly different, you know, unless it's like from the CDC or from like some really, really trusted source, I try to not do that, because I think you're only as good as the quality of your data. Yeah.
Since you're talking about where you get information, and since you've been to the dark side, I wanted to know if there's really good data that the dark side has that we don't have, and should we be partnering with them, you know, to
Where
get
do you
that?
live? Where do you live?
In Nebraska.
Okay. Well, I think the answer is yes. And I don't know. I know a bunch of states have this. In Oregon, we have a all payers, all claims registry. No one's allowed to actually access it, but it exists in theory. And I don't know, Rachel, do you know what, 10, 11, 12 other states have this?
We're theoretically getting it in Virginia, but it's been held up. So the health department is supposed to have access to it eventually. But they've been going back and forth about whether or not they're going to allow it to happen.
So that is, in theory, if your state has it, a great source of data. Well, it has the potential to be a great source of data because, like in Oregon, all insurers are required to submit a lot of super detailed claims information, including cost information. I think the challenge is that even though they're required to do it, they sometimes don't do it, and the quality of it is sometimes questionable. When I worked for Blue Cross, yeah, they had great data, and people were always trying to get them to, in the name of good works, give them their de-identified data, and almost never did they do it. But they were a particularly dark brand of the dark side. You may have more success with other insurers in your area. The cost stuff is so hard, though, because it's so proprietary. People don't, no insurance company, it's getting better, I feel like, in this era of transparency, but no insurance company wants any other insurance company to know, like, how much they're paying their providers. And they definitely don't want their providers to know how much other insurance companies are paying other providers, because then they get upset. Recently, the CMS put out this giant data set for Medicare, and it is pretty much every Medicare doc in the country, how much they are getting paid and how much they billed for a ton of different Medicare services. It's actually kind of shocking to me that you can go in and look up people by name. Now it's Medicare rates, but it's pretty, and so that means it's a certain set of services that they're not treating a lot of kiddos. But it's actually, and the New York Times actually has this great wiki where you can go in and you can look up for your state, you can look up any doc, you can look up the average cost of tons and tons of different procedures. So if you're looking for claims cost information, that's a really good place to go. Yeah.
So since you're relying so much on external data and, having not done this before, what are some of the common mistakes or red flags that you would look for when you're thinking about relying on different cost-benefit analysis?
Good question. So one is, and I'm just going to show you this really quick, one will come out when you do your sensitivity analysis. Potentially, although I guess I didn't really do it here. When you do your sensitivity analysis, what you want to do is alter your assumptions and see what how much the results change. And so here, all I did was I have my inflation rate, my discount rate, and those are really the only things that I altered for I guess I altered the number of kids vaccinated, but those are the only things that I altered to see how much it would change my bottom line here. And I kind of found that I'm getting a positive ROI no matter what, although as some of you have pointed out, some of my assumptions were not, or my calculations were not accurate. But, if I increase my, what did I do here? Oh, this was, okay, right, this was my initial one. So depending on what I do to my discount rate and my inflation rate is going to alter what my ROI is. If I were really being thorough, I might alter some of the estimates that I got from the external data. Like, what if the cost of treating cervical cancer was only $20,000? Or what if the survival rate was way longer? How would that change my model? I think the biggest thing that I've seen, that I've done myself and seen as an error, is incorrectly translating external data to my situation. Whether that is, it's not so much like getting it down to your exact population, like it's national data, it's state data, it might make a difference, but probably it's not gonna make that much of a difference. But it's more like converting it to the right unit in order to apply to your data. So are you talking about, for example, like at a household level, or are you talking about an individual level? And that can make a big difference in your assumptions. And I think just double, triple, quadruple checking everything and have someone else basically like challenge you, ask you a lot of questions about why you did what you did. I feel like if you are able to really explain it to someone else, preferably multiple someone else's, then, and you can walk through it yourself, like you leave it, you come back to it a few days later, and you're like, I'm going to kind of not redo the whole thing, but like I'm going to go back through the process and make sure it still makes sense to me. But I do feel like it's that applying it appropriately and grabbing the right numbers and treating them so you're taking units that are comparable and putting them together. And then I think that just the other one is, depending on your issue, there's a lot of different sources of data out there. They may be wildly different. And so I think you just need to be really thorough about looking for, is there wild variation out there? And if so, how are you going to make a decision about what to use?
I was wondering about the cost of treatment. So if that cost of treatment is several years in the future, would it ever make sense to apply a medical inflation rate to it?
Yes.
Okay.
I did not do that here. We'll talk about that after the break, but yes, if you are doing something with healthcare claims, I actually recommend using a higher rate of inflation to treat your medical costs than you would just income or revenue or employment or anything else. Yeah.
So I'm going to be very cynical.
Yeah, go
on
for it.
put on the cynical hat of maybe perhaps even coming from the dark side, because I hear this from our budget director at Medicaid. So if that person's going to stay in Medicaid, they're actually going to cost the state money over time. And
True.
so that, so when we have to be really careful when we start saying, oh, we're going to save all this money by helping the person live longer, have a better quality of life. They're like, yeah, but they're going to be in Medicaid longer and cost us money too. So it's like a really, in the dark side. What do you think they do at the dark side?
Except that, I mean, yeah, I think that's totally right on. But
But if you it's a little different if you're preventing a disease as opposed to if you actually help somebody who has a chronic illness get better and they can go out and work. Then I think that you get more bang for your buck from the Medicaid perspective.
True. Well, and if they go out and work and they are no longer eligible, and then they come off. Yeah, I think that is totally a really good point. What other, and this will come up tomorrow when we talk about home visiting. But if one of the goals is to reduce TANF spending, it's that tension between getting kids enrolled in services. You want to get them enrolled in Head Start, but Head Start also costs money. So that's also where your perspective is really important. I'm not saying you craft your perspective specifically to exclude the costs you don't want to talk about, but it can be really helpful if you're like, okay, this is a federal cost, and I'm not talking about federal costs here. I'm talking about the cost to my state of running this program. And so this, so TANF doesn't count because my state doesn't pay for that, or whatever. Does that make sense? I think that's a really good point. Okay, so I think actually that I am just about done. So yeah, I mean, basically, if you had done this, you want to go back to who is it for, what conclusions am I drawing from it. What are my limitations? And clearly, there's a lot of limitations. And hopefully, the more time you have to spend on this, the more people you can. And I don't want to imply you need to carve out 6 months and 4 FTE to do this work. I just think the more thorough you can be and the more eyes you can get on it, the better. And then just be honest about, in this example, most of our savings came from Medicaid. So while it would be great if more of our savings came from the fact that the government's getting more taxes, because that just has a wider appeal. It gets away from the issue of if they're in Medicaid, they're going to be costing money anyways. But that was the fact of it. And then obviously our benefit calculations were extremely rough / mildly incorrect. So that's what we might write up. And that is actually all I had for this afternoon. And I think we're a little early, but any questions before we have a break? No? Okay. Well, thanks, and we'll talk more about doing a specific example later.